who is from Sunrise Institute, Hyderabad, a very well-known center for the joint replacements in the country. And both Dr. Chatterjee from Calcutta and Dr. Adarsh from Hyderabad, on behalf of scientific committee, my colleague Dr. Krishna Kiran, our president Dr. Khincha, and the executive board and trustee members of the ISHK, I thank both of them for agreeing and sparing their valuable time and coming here on the online teaching program. So before Dr. Chatterjee can join, I would suggest and request Dr. Adarsh to share his screen and give his talk. I think it's on balancing plus some bearing choices.
Chatterjee is on.
Can you see me now?
Yes.
Yes. 1 minute. Dr. Chatterjee, we can hear you.
I can see him too.
Yeah,
He's got Dipak Dave's name on that.
Yes. Can you share your screen?
Yeah, I can share my screen. Yeah. Okay.
While Dr. Chatterjee is sharing his screen, I must thank Dr. Dipak Dave and the entire board and Krishna for having done a wonderful job. This is the last CME in this particular term. Online teaching program. I hope it continues in the same way next year.
Yeah, can you?
Yes, we can see. We can see your. Yes. Go to the slideshow.
Yeah.
Yes, just move the slide.
Yeah, can you see? It's on slideshow now.
Yes, just move the slide. Yes. Okay. Just back, Dr. Chatterjee, please let me introduce you.
Can you hear me? Hello.
Yeah. I hear you.
Okay.
Yes. So, because of the prior commitments and some positive line, Chatterjee was to talk first already. When he is able to join, senior sergeant from Kata Apostles, and he's going to speak on the technique of two-stage revision in infected TKR. So with this time, please share your screen on behalf of our education committee, Dr. Khincha, President. We thank you very much for spending your time.
Thank you so much for the opportunity. It's really wonderful to be a part of the seminar and to see all of you. I hope you can hear me clearly.
Yes, we can.
Okay. So my brief is on the technique of two-stage revision in infected TKR, which even though there is some sort of a paradigm shift towards the one stage, and it is becoming increasingly popular, but as of now, I think the two-stage is still the gold standard. Now, looking at the literature, this was first put forward by Insall in 1996 in his paper, where he showed the survivorship of almost more than 75%. In his paper, there were 64 hips with multiple bacterial infections, and but overall, with this two-stage technique, there was 68% was satisfied, and there were a significant number of excellent results. So there were many other publications as well subsequently, and most of them actually had very good results, which sort of established this as one of the probably the most popular and the technique for revising an infected infected knee. Subsequently, of course, there were people who came forward with the one-stage revision, but I think it is still the gold standard today. So what are the indications where you would prefer the two-stage reimplantation instead of the one-stage? And some of the absolute criterion are if the infective organism has not been isolated, so you don't know what is the organism, if the patient is immunocompromised or is very in poor general condition, or if the infection is highly virulent or a resistant organism, If there's a sinus tract, this is a relative contraindication. Some of the people believe that you can still do a one stage if there's a sinus, but it's a relative contraindication for a one stage. And overall, you see the two stage will allow the patient time to overcome the infection, and which is probably responsible for the uniformly good results. So the two-stage revisions, obviously, there are two stages for the surgery. The first one is the stage one, where it involves exposure and a thorough debridement, explantation, and then the antibiotic spacer implantation. And in the stage two, again, you may have to do one more debridement and then removal of the spacer, restoration of bone deficiency, and then final implantation of the revision implants. The approaches for the stage one is usually the medial parapatellar is fairly standard and usually sufficient, but sometimes you might want additional exposures, which is typically either the quadriceps snip or very rarely a tibal tubercle osteotomy. I think a very important part of the procedure is the debridement. And here you need to clear the medial and lateral gutters and the suprapatellar pouch. After removing the poly component, you can get access into the posterior compartment, and that needs to be cleared out. The collateral ligaments, however, in the two stage are usually preserved. And that may not be the case in a one stage, where very often the collaterals are sacrificed and most of them end up with a hinge. But in the two stage, one can be careful to save the collaterals and have a lesser degree of constraint subsequently. So the debridement has to be extensive and thorough with copious lavage. And this is a very important part of the whole procedure. Then comes explantation, and I think this is also an extremely important part of the whole procedure because it can facilitate or complicate the subsequent implantation. And this explantation of the pre-existing components, it has to be done with minimum bone loss and minimum damage to soft tissues, because if there is more loss of bone, then it will influence the type of implant and additional armamentarium may be required. So this picture shows a lot of bone which has come out with the implant, and this is not what we should. This is undesirable, something to be avoided. So we have to prevent loss of bone. We have to prevent fractures from happening during the procedure. And sometimes you may have a lot of problems when removing the components, especially if there are sleeves and stems, and the ligaments obviously have to be protected. I think it's very important to have the correct instruments in order to do a successful explantation. There can be general instruments, as you can see, there are specific instruments, and that's very important depending upon what is the type of implant which has been used. And then you can use, if you have access to ultrasonic cement removers and metal cutting instruments, and that is sometimes it is required. There is a certain sequence to the removal. The first is to remove the polyethylene insert, and this is important because it gives progressively increasing exposure and accessibility to components. The next thing to tackle is the femoral component, then the tibial component, and lastly the cement and the patella. Now, it is very important to understand that this removal of the implant has to be in the metal cement interface and not the cement bone. This is to prevent bone loss and invariably needs removal to adjust flexion and extension gaps. Instruments, there are different kinds of instruments which can be used, and we'll see some examples of those. Then, of course, as far as the femur is concerned, usually we start from the anterior part and then go on to the chamfer, the distal cut, and the posterior comes in the end. It's a lot more easier to remove a CR femur rather than a PS because the box tends to get in the way, and if there are peg holes, then that is another difficulty. It increases the degree of difficulty. Some examples here, you can see we can either use an osteotome, or you can use the jiggly saw in some cases, or you could use an oscillating power saw. And in the end, it is good if you can get the grabber or the instrument to hold on to the femur to slap it out gently. As far as the tibial component, well, if in a partial revision, you can retain it at times, but in a total revision, you will need to remove it. So it has to be exposed on all sides. The knee needs to be flexed. And one of the techniques is to use the stacked osteotome technique. As you can see in this picture, you can put one osteotome on the other, and that tends to loosen the implant. The pictures on the right, they show that this is how you should remove. The cement should stay back, and then you can tackle the cement later on. The patella can be removed, but otherwise one should be very careful, because in an all poly patella you can saw it off and then take out the pegs later on. Uh, and then of course you need to remove the cement, and that in the infected case has to be very, very thorough. You have to take out every bit of cement. You can't afford to leave infected cement lying around, because that will again lead to a recrudescence of the infection. So these are some pictures to show the painstaking removal of the uh, cement. So central to this process of the two-stage revision is the antibiotic spacer implant. This has a very important role. It delivers a high concentration of antibiotic locally. It provides the patient comfort and mobility. It maintains the joint space and gives stability. It temporizes the reimplantation, and that's important because it gives the patient time. It gives the patient's host immunity time to fight the infection, and which is why I think what is responsible for the good results that you see in this with this procedure. And it also helps in improved soft tissue healing and tension. So we'll talk in some detail about this and kind of spacers. The prefabricated implants are available, then the non-articulating spacer, which is traditional. The recent preference is for the articulated molded cement spacer. And then, of course, there is the autoclave spacer implant, which was used by Lotke's group. Now, this is the prefabricated articulating spacer. It conforms well to the bone because there are different sizes available. It preserves joint space and usually preserves movement. Does not contain antibiotic all the time. So that's a problem, and it's a little bit expensive to use. Now, this is the static cement spacer, which is useful because you can put in whatever antibiotic you want to use depending on the culture sensitivity. However, it prevents joint mobility and it can cause muscle wasting and joint stiffness. So, if you are planning to do a two-stage procedure, a second knee joint implantation, then it's probably best avoided. But in cases where one wishes to do fusion, I think this is a good implant, good technique to follow. What we use almost universally now is articulating spacers. Now, these can be made on table by the use of molds. This allows joint movement, which is infinitely better for the soft tissues. It prevents their integrity, and you can obviously use antibiotic of choice. Now, this is the mold which we use, where we push in cement, allow it to set, and then once you remove the mold, you have these beautiful spacer implants, which are very much similar in shape to the original implant. Now, this is a technique which was in vogue some time ago, where the femur was removed, it was autoclaved and then put back, and a fresh all poly tibia was used. And the cement had high concentration of antibiotics, but it's not so much in use now because of legal constraints. And I think there are some they do not allow you to reuse the implant. So that's why this has sort of gone out of vogue. But when it was in use, it was a useful technique. Spacers are not without their complications. Sometimes they may not control the infection, so you might need to redo the first stage surgery and change it to fresh spacers. They can sometimes cause increased bone erosion by abnormal movements, and then you can have bone erosion at times. You can have dislocation, as you can see in the X-ray, and sometimes the implant can break, which will and if the infection is not controlled by then you need to put in a fresh spacer. Coming to the second stage, or the stage of definitive implantation, here the challenges are that one has to address bone defects, which can be done either with grafts, with allografts, or with metal. And then, of course, you need to have stability of the implant, so which requires a minimum two zones of fixation, and usually may need a metaphyseal fixation. And then, of course, the instability of the soft tissues, particularly the collateral ligaments or the coronal plane instability, needs to be addressed by using appropriate constraints. Some example here, the options for managing large bone defects. So one is allograft bone, or you could use wedges and augments. And but of course, if the metaphysis is destroyed, then you need to either use trabecular metal to build it up, or metaphyseal sleeves, which are part of the implant. Bone defects can be machined, and then it can be, if you have access to allografts, then allografts can be used to pack the defect around the stem. This is useful because it restores host bone, and subsequent revisions, if required, are easier to do. Large preserved allografts can also be used. The example here shows a split femoral head. The problem here is sometimes there is an inadequate osteointegration of the graft, so then there's a graft failure and can lead to re-revision. But this is an option which one can consider. Augments and wedges can be used if the metaphysis is more or less intact. Then an example here that you can use the wedges and augments along with the stem if the metaphysis allows. Trabecular metal is a highly porous metal which is basically made from a sponge impregnated with the tantalum, and then the sponge is burnt, and it gives rise to this kind of structure which is highly porous and allows the host bone to grow into it, so it has a high osteoinductive effect. It's a good ingrowth construct. It provides a very stable construct with load sharing. The problem here is that everything has to be cemented, so that is a limitation of the trabecular metal cone. Example here, this is how the cones are shaped, the tibial and the femoral cones, but they are very, very useful devices to attain metaphyseal fixation. The other option to address bone defects in the second stage revision is the sleeve. This is actually incorporated into the part of the implant. They have a stepped geometry which loads the bone, and it facilitates host bone reformation by Wolff's law, and generally causes a restoration of the bone, and it gives almost immediate fixation and very good space. So this is the tibial sleeve. It comes in various sizes. The smallest one is a cemented implant. The other bigger sizes are non-cemented, and it allows a certain degree of internal external rotation. And I think what's very useful about the sleeve is that you can put it in whichever way it goes in best, and then the tibial tray can go in independent of the direction of the sleeve. This is the femoral sleeve. Again, comes in various sizes. So the metaphyseal sleeves give increased rotational stability, and the other advantage is that they can be used in conjunction with the RP, or rotating platform TKR. Now, this RP, although the use in primary situation has gone down to some extent, but it is now fairly standard in revisions, because what it does is it uncouples torsional forces from the flexion extension and the other displacing forces, and therefore it gives rise to better mobility and increased sustainability and increased lifespan. So just to end with a case example, this was a 68-year-old female. Bilateral TKR was done some years ago, developed infection in the right knee about a year and a half back. Sorry. Treated elsewhere with debridement and polychange, followed by antibiotics, and then thereafter, this patient came almost a year and a half later with antibiotics. Various antibiotics had been given. Patient had a sinus with copious purulent discharge, grew methicillin sensitive Staph aureus, And otherwise, there were no systemic sepsis, but the patient had certain medical comorbidities. So first stage of a planned two-stage procedure revision performed was massive bone destruction was encountered, extensive debridement of necrotic tissues done, collateral ligaments were preserved, articulating antibiotic spacers were made from a mold impregnated with the vancomycin, and the space was put in place. And we also used stimulant. This is a picture before the implant removal. And after removal, there was, you can see the extensive bone destruction. Uh, this is the molded spacer in place and the post-operative X-ray, which shows pretty good alignment actually. And this patient was very, very comfortable post-operatively and was ambulating fairly well. It took about 6 weeks for the ESR and CRP to gradually return to normal. And what was very remarkable is that that's the really the hallmark of these articulating spacers, that they have a very good preserved range of motion of the knee and also stability and mobility. And then 4 months later, the revision was planned. And at that time, the patient 100% flexion, the soft tissues were very good. The collaterals were okay, but there were massive capillary defects. This was, in fact, on the table before the second stage revision. You can see the knee bending so well. But inside, there was massive destruction. And after removal and debridement once more, this was a plan where we had to use sleeves on both the sides with stems and with a TC3 kind of a constraint. These are the sleeves in place, these trial sleeves in place. This is the trial in place. Uh, these are the definitive implants with sleeves on both the tibial and femoral sides. Post-operative X-ray, as you can see, and this was the flexion at the end of the surgery, at the end of about 6 months. So infected TKR poses a serious challenge to the surgeon due to bone loss and soft tissue contractures. So as of today, the two-stage is still the gold standard, although there seems to be a shift happening towards the one stage, which has its own advantages, I have to admit. The conventional monoblock antibiotic impregnated PMA spacer is now has been replaced by the articulating spacer, because that prevents soft tissue fibrosis and muscle atrophy. And massive tibial and femoral bone defects can be effectively managed either with sleeves or with cones, or sometimes with wedges and augments, which are usually required in the second stage to reconstruct the defect. So I thank you for a patient hearing.
Thank you, Dr. Chatterjee. I know you need to leave, so just
It's okay. I can spend time for questions and discussion.
yeah,
Not
we'll
a
take a
problem.
couple of questions. By the time we can see something in the chat, I have two questions for you. Number one,
Sure.
after the first stage, when you do the second stage, do you
Yes.
give antibiotic holiday period, and do you always aspirate and do, or you only rely on ESR CRP?
Okay. It's a very good question. So this concept of antibiotic holiday was there some years ago, but if you look at the new publications, then they have done away with it. So there's no antibiotic holiday now. And yes, I do aspirate the knee, and then if it still shows a culture, if it has a growth, then you will need to redo the first stage once more. You can't really afford to take a risk and do the second stage. ESR CRP, of course. The other thing is, in cases where which are a little bit on the borderline, what I do is I do a frozen section. I send 5 samples for frozen section and look at the leukocyte count. And if it is more than 5 in a high power field, then I think I would defer the definitive second stage. So that's the way I go.
Adarsh, what is your strategy for the two stage? Do you always aspirate, or you rely on the clinical findings and blood test?
Earlier, we were doing blood tests and clinical findings only, but I think the last 2 to 3 years, aspiration has become the norm. Even all the publications speak about aspiration. So we have started doing aspiration since the last 2 to 3 years.
Right. Okay. Dr. Chatterjee, my second question is, what is your guideline for cementing the articulating spacer? Is there any specific tips you can give?
Yes. So we do cement the articulating spacer, but it is a kind of a loose cementing. Like something like the 1.5 revision, where you do a loose cementing with antibiotic impregnated cement, so that when you do the revision, you can actually take it out without too much difficulty. But yes, we do cement it because that adds to the stability, and usually these people are very, very comfortable. I can even tell you that few patients actually never came back. They just continued to manage with the spacer implant.
Yeah, I think that is a point which sometimes they are so comfortable, they are not very keen to come back again.
Yeah, because there's an expense involved at the same time, so that sort of dissuades them.
That's where that cement, as you said, sir, it has the value. Just in case they don't come back, that those days.
Dr.
Yeah,
Khincha,
I mean,
any question from you?
So, Dr. Chatterjee, what is your time frame of use of antibiotics in a sensitive organism on the first stage?
yeah. So I generally use 6 weeks of intravenous antibiotic.
And
Six
then,
weeks of antibiotic, and then if the patient has a normal ESR-CRP and negative cultures, then I go ahead with the second stage. If the ESR-CRP are still on the higher side, then I switch to oral antibiotics. I have stopped giving the antibiotic holiday now, and as per the more recent publication.
but if
So
you
then,
if the patient is on antibiotics, I don't think we will get a positive culture at all, even if you do a gene study.
yeah, that's true. But
So the aspiration becomes a waste of a procedure in case you don't give a holiday period, because in presence of even single dose of antibiotic, we are going to get a negative culture come what may.
mm,
Others, what is your threshold for biofire? How, Dr. Chatterjee and Dr. Others, how frequently you use the biofire when patient is on antibiotic?
So do you want to take first?
yeah, no, you carry on, carry on.
Yeah, we've recently only started using Biofire. It gives us a good array of results, so we can just kind of cover up the things that we would normally not look at. But it's a very recent thing. We've not used it for more than a year now, so that's the thing. I don't know about Chatterjee sir.
Have you been able to correlate with the normal culture report, because we have been using it, but sometimes biofire shows something and the culture doesn't show, or the vice versa. So
Yeah,
that
I think
discrepancy
it's yeah. I think it's too sensitive. I mean, it takes up even like small traces also, is what I understood. So
The problem with biofire is that it will detect even dead bacteria,
exactly. So
and
it's going to
therefore,
sometimes take you down the wrong path.
I mean, it's useful, but I think you have to look at it in the perspective of everything else. You can't rely too much on that. The other thing is that there are certain bacteria which it doesn't detect. So you can have false negatives and you can have false positives. So this is the problem with biofire.
What is your opinion about use of gene experts for the mycobacterium, and also what is the percentage of positive anaerobic cultures you have in your two-stage procedures?
I do not think it has a place in routine practice because both are fairly rare conditions. But yes, if you are suspecting if not responding and somehow your ESR-CRP is not settling down, and you have a borderline sort of clinical picture, then yes, then you want to think about mycobacteria. You might want to think of fungal infections. I think fungal infections are probably a little more commoner than atypical mycobacteria. And then, yes, these probably have a role.
So I will go to the next question on the same corollary. What are the, for the sake of the participants who are, say, junior, sub-junior, or semi-junior, or semi-senior, what are the giveaway points on the table for you to suspect a Mycobacterium tuberculosis?
Uh, Softening of bone, significant softening of bone if there's sort of granulation tissue. And, these are cases where if you do a frozen section and a biopsy, you will not find a lot of neutrophils, but you'll find a lot of lymphocytes and macrophages. So if that is the picture you get on microscopy, then I think you need to think about all this. And I think the safe thing to do here is then that you don't go for the definitive implantation. You put in one more antibiotic spacer and send all the biopsies and cultures, back tech and everything, and then wait for it.
I think further to your suggestion, I think you mentioned in your talk about taking tissue samples from
Yes.
5 places to send for the culture. I would very strongly tell all colleagues to send one of the sample for histopathology also.
Yes, absolutely. Absolutely.
All the 5 samples is split into 2, sir. I think is better.
Sorry, Adarsh, sorry.
In all the 5 zones, sensitivity is better. You can find something somewhere.
No, I have a question. I mean, how common is mycobacterial infections? Is it?
I would say it's not that uncommon in our country, although it's not of the same category as a few years ago. But that's when you have a bacterial situation on culture, and there is a persistent discharge, and the fellow is not settling down. Then mycobacterium comes primarily. Then comes the anaerobic fungal cultures or fungal infection. But mycobacterium is there, and I think there is a role of gene expert, which is not very expensive, and you get instant results of that particular, along with histopathology. Histopathology will give you many.
I think as Dr. Chatterjee mentioned, when the wounds are not healing, the reports are not coming down, the clinical picture is not improving, you certainly need to check for fungal and NTM both. These are the 2 important points which we need to keep in mind when the things are not getting better as expected.
In your practice, Dr. Chatterjee, have you ever thought to change your mind on specific situations to go to a one-stage procedure?
No, not really. I have changed my mind sometimes to not go for an implantation, but go for a fusion. That I have faced that situation, especially when patients are extremely reluctant and they want a guarantee that the revision implant is going to last forever. So in some cases, I have changed my plan to a fusion, but I have never really gone ahead, and I've not had the courage to go in and do a one-stage revision. But I mean, I think gradually things are changing. People are shifting increasingly towards the one stage. I accept that. What about you, Khincha? Are you still doing one stage?
All of us old-timers, so-called old-timers, are still scared because we have seen fulminant infections in the past. But then with exposure, with people getting out to see some other centers and getting the techniques and getting the courage and seeing some of the people like Krishna do some here, then the paradigm will shift towards one-stage procedure in sensitive organism infections.
Let me tell all the participants here that we have a wonderful session on PGI in the next meeting in Pune, 10, 11, 12 April, the East annual meeting, and all these points of one stage, 2 stage, including the Master Javed Parvezi is going to be there. So please join, register yourself, and we will have answer to all these points further in detail what Dr. Chatterjee has beautifully mentioned here, covering all the aspect of implant removal, taking care, 2nd stage, a bone defect, and cement spacers, and then re-implantation. So, Dr. Buddhadev, on behalf of Dr. Khincha, our President, Scientific Committee, my colleague Dr. Krishna Kiran, and all the members of Executive Board and Trustees, I thank you for spending your time. I know you were pretty busy with other schedule, but I really thank for your spending time and be here on the teaching program. Thank you very much.
Thank you. It's a pleasure. The honor is mine. Thank you very much for the opportunity, and it
Yeah.
was great to
See,
interact with
see you in Pune.
Yeah.
Yes, absolutely. Okay, I think I'll ask you. Okay, thank
Yeah.
you very much. Yeah, absolutely. Looking forward to being here.
Others, can you start sharing your screen?
Stop
Sharing, sir?
I'll stop sharing mine.
Thank you.
Yeah.
Right. Okay, I'll start sharing.
Thank you very much.
So, Deepak sir, do you want me to start with the balancing of the hip? I think that's the most important topic here. And if we have time after that, we can go for the bearing surfaces.
No issue. Both are fine.
Right, sir.
Do you want to introduce this man, Dipak?
Are you able to see my screen, sir?
No, it's still moving. Dr. Khincha, you can speak about him.
I don't know anything about Adarsh Annapareddy, except that he's a young budding surgeon from a very busy institute in Sunshine Hospital in Hyderabad, and happens to be a prodigy son of one of the pioneers of arthroplasty in the country, who has done a lot of work, Guru Reddy. And I have seen him grow in the last 5 years. And I can assure you, and I can tell you without hesitation, that he has overtaken many of us in his presentation skill, in his humbleness, and in the way he has done his scientific studies. So I wish him all the best. And
Prem
others,
in next 5 years, people will say that he's not son. It will be reverse. Guru was
his father.
father.
Oh my
Yes.
goodness,
Okay.
sir.
Yeah.
This is
I
too
was
high
about
praise.
I was about to say that in the next 3 to 5 years, I think Guru is going to say that I am working for Adarsh, just like I say that I am working for my daughter. All the
Others,
best.
your screen is not coming somehow or the other.
Sorry, sir. Let me just, I'll stop sharing my video. Maybe then it will work better. Sorry about that.
While the screen is coming on, I also like the way he has got his camaraderie along in his family, his respect to his family, and his closeness to his brother-in-law. They are
Yeah.
like brothers more than brother-in-law.
Yes, sir. Thank you so much for the lovely word.
You could see your screen earlier.
While Adarsh is getting his screen, Poonam, can you hear me? Is Poonam there?
Am I on now, sir?
No, not yet.
Yes,
Yes, you are
now.
on.
Yes.
Thank you so much for the wonderful words by two very dear people, and I really respect both of them so much. It's high praise coming from both of you. Thank you. I'd like to thank you both for inviting me here today. ISHKS is one of my favorite organizations because I started, I remember during my training days attending these meetings, and I really enjoy these meetings. So I would love to start off my talk, which is I feel a very pertinent topic about balancing the total hip arthroplasty, because we always talk about balancing the knee. There's so many conferences, so many things we discuss about balancing the knee, but we don't really talk about balancing the hip that much. I think it's even more important than balancing the knee. So I'll tell you why I feel so. Total hip replacement is all about the balance. It's what I believe. It's not just putting in a cup and a stem. I think there's much more to it than what meets the eye. The perfect THR requires lots of planning and tinkering. You see this flow chart, there's so many things that can go wrong. You get the right depth, the right height, right angular placement. In that, again, you have inclinations and anteversions, and so many things that can potentially go wrong. So what are the factors that contribute to hip stability? Let's have a look at that first. So there are multiple factors here. One is the cup anteversion, cup inclination, the cup height, cup depth, center of rotation, femoral anteversion, femoral head size, head neck ratio, offset, the limb length discrepancy, and the abductor sufficiency. So if you think about it, it's not as easy as people make it out to be. There's so many things that can go wrong. three headings, and then I'll go for subheadings of each. So let's talk about component positioning first. Sir, you're able to hear me right clearly?
Yeah, we can see your slide, but not the video or anything.
Yeah, so I just switched off my video to just make sure there's no lag.
Okay.
Okay, so the first part is the acetabular component positioning. See, the adequate medialization of the acetabular cup to the quadrilateral plate is very important to reduce the joint reactive forces. So you have to try to maintain the native hip center as much as possible. And proper positioning of the cup within the Lunex safe zones is a very good starting point. So nowadays, people are now debating whether this Lunex safe zones actually make sense, but it's definitely a good starting point. Because you can't just go in without a target. You have to start off with some idea, maybe 40 degrees of inclination and 20 degrees of antiversion. Whether you want to modify it or not is not together, but at least you should start off with this safe zone. Make sure that you've medialized well enough to reach the quadrilateral plate. So that's about the placement of the cup. And then you talk about the angular placement of the cup. So this is Lunex safe zone. This is his paper where he suggested that you have to have acetabular antiversion of 15 degrees plus or minus 10 degrees, and acetabular inclination of 40 degrees plus or minus 10 degrees. And then there was a concept of combined antiversion, where you have to have the combined antiversion of the cup as well as the femur to be up to 25 to 50 degrees, and you can test it with a coplanar test. Now, the new concept has come called functional placement of the cup, something similar to functional alignment in the knee. Functional placement of the cup using help of robotics and virtual range of motion. You can place the cup in the adequate angle as per that patient's anatomy. It's no longer we're sticking to only 40 degrees and 20 degrees. We're actually tailor-making the cup position as per that patient's anatomy and spinopelvic parameters. I'll touch upon this in the further slides. So, as I said, component malposition can cause so many issues. If you have excessive antiversion, you can have an anterior dislocation. Excessive retroversion can have posterior dislocation. Too much inclination can have superior dislocation. And too horizontal a cup can actually lead to impingement. So many things can go wrong. So let's talk about the femoral component now. Femoral offset should be restored precisely. You have two kinds of offsets, offset and the anterior offset. In some cases, like dysplasia, it is advised to even increase the offset as well. So that's very important that we know what is a femoral offset as well. So if you can see in my slide, I hope you can see my cursor. This is called offset. And the anterior offset is on the lateral view, where you're looking at the on the lateral view, you're seeing how the placement of the femur is. If in hips with higher native femoral offset, higher offset neck and head can be used to restore the muscle tension and increase the stability. So look at this picture on the right here. The one on the right, you have a shorter offset, and your ligaments and your soft tissue structures are quite lax. So you're not going to get the adequate tautness and adequate stability on this particular joint. But if you look at the one on the left side, you can see a nice offset. The higher offset has actually nicely made the soft tissue structures around the hip joint taut and given you that stability. Rarely, if tissue tension is not adequate, sliding osteotomies of the GT can be done. You take an osteotomy here and you distalize it and lateralize it so you get your soft tissue tautness. An excessive offset is also not a great idea. It can lead to too much of tightening of the abductor complex, and it should be avoided. Again, in femur, component malposition can mean three different planes. You can have varus or valgus placement. This is what we normally talk about. That's why we have to lateralize your entry point in the femur. You have to use the box cut nice and lateral so you don't go into varum. Valgum is also possible. Then in the transverse T, you can either be too retroverted or too antiverted. So we usually aim for around 10 to 15 degrees of antiversion. But high antiversion, very high antiversion can lead to anterior dislocations as well. So you have to be wary of that. And then, of course, in the transverse, in the sagittal plane, you could have anterior and posterior tilt as well. So these are all component malpositioning in the femur. So stability of the THR can also be determined by the femoral head. So you have a 36 mm head with a liner thickness of at least 4 to 5 mm to improve the jump distance before dislocation. It helps to avoid impingement. So this concept of jump distance, I'll explain over here. A smaller head has a higher chance of dislocation. I think most of us are aware of that. And a bigger head gives an improved head to neck ratio. So that reduces the risk of impingement and that leads to a better jump distance. Basically, jump distance is the distance that if the hip can go before that head dislocates. That's a jump distance. So usually they say 32 head and above are pretty safe. So you can see in this diagram here, a smaller head has a lower jump distance and a larger head has a larger jump distance, thereby increasing your stability. So now let's talk about impingement. Impingement leads to dislocation. Remember that impingement doesn't just lead to wear, doesn't just lead to corrosion on the implants, but can actually lead to dislocations as well in the opposite direction. So impingement is again of three types: bony impingement, implant impingement, and cement impingement. This is an implant impingement over here, and this is a bony impingement. And cement impingement can happen when you have used cemented implants and you have not removed adequately your extra cement. It could lead to impingement as well. What are the different methods to avoid impingement? Proper implant positioning, obviously, as I said earlier, too horizontal cup can lead to impingement.
Adarsh, we lost your voice.
How about now, sir? Can you hear me now?
A little wavy, a little unclear.
Yes, sir, you can hear me.
Not yet.
I've turned off my video. I think.
Puram, is there a problem?
Yes, sir, can you hear me?
Yeah. Is there a problem with your screen moving?
Whether you're able to hear me or not.
Yeah, now we can hear you.
Right. I'm sorry about that. Sorry about the poor connection. So yeah, these are the different methods to avoid impingement. Robotics and virtual range of motion have also helped in reducing the chance of impingement, which I will show you in the further slides. So this is an example of virtual range of motion, or VROM, which we do with the Mako robotic hip. You can see that you take your hip through a virtual range of motion in this particular angle of 40 degrees inclination, 25 degrees antiversion. And then you see as it goes up, you start to see an impingement on the cup. You see a red dot which will appear now, which proves that you have, this is a bony impingement that you can see. And in this particular example, you'll be seeing this cup impingement. So by reducing the antiversion on this cup, I can get rid of that impingement over there. So this is something known as virtual range of motion, which helps to avoid impingement. The next important thing, and definitely a bit of a bugbear now because a lot of people are very anxious about this nowadays, is the leg length. In the present scenario, it's imperative to restore the leg length equal to the normal side. If more than 3 to 4 centimeters short, you should consider a subtrochanteric shortening osteotomy to avoid sciatic nerve palsy, and should also differentiate between supratrochanteric, infratrochanteric, and combined shortening. Kiran sir has a wonderful talk on this particular topic, so please do look into it. He has a paper on this as well. So if you have time, please look up that paper. So leg length, supratrochanteric shortening is when the femoral head center is lower than the level of the GT and the LT is at the level of the teardrop. Usually an STSO is not required here. Modular implant with short neck can be used instead. Infratrochanteric shortening is when the femoral head center is higher than the level of the GT and LT is superior to the level of the teardrop. Here, usually a shortening osteotomy is required. Right, now let's move on to the soft tissues around the hip joint. These are the different capsular ligaments of the hip. So in the knee, we always talk about the MCL and the LCL and the PCL. Here we have these ligaments. In the front, we have the iliofemoral ligament and the labrum. The ligament teres is inside. And then you have the ischiofemoral ligament on the back. This is a pubofemoral ligament, which is released when we do the direct anterior approach. But yeah, we don't usually worry about this too much. But these are the different soft tissue structures. The hip girdle muscles, as you all know, I'm not going to go into depth over here, but these are the ones which are also giving you your stability. And usually the posterior approach people were more concerned with the short external rotators. And of course, the abductors have to be preserved and you have to be very, very safe near the abductors. So the hip girdle muscles, in brief, flexors are the iliopsoas, the rectus femoris, extensors are the gluteus, adductor magnus, and the hamstrings. Adductors are the pectineus and the gracilis, and the abductors, as we all know, the gluteus medius and the minimus. External rotators are the ones that we normally take a flap off, the gluteus maximus, piriformis, the gemelli, and the obturators, and the quadratus.
Your voice has gone, Adarsh.
Sorry, sir, I don't know why the connection is behaving like this. Is it any better now?
Yes.
Yes, sir. Sorry about that. I was just saying, if you want to restore soft tissue tension, there are two ways to do it. One is you can increase the neck length, one is you can increase the neck offset. To increase the neck length, you're going to get a good soft tissue tension, but you're also going to end up lengthening your limb.
Others, we cannot hear you properly. I think there is no voice coming. Can you hear me?
You like me to log out and log back in, sir? Very quickly.
Dr. Khincha, can you hear me?
How about me?
Poonam?
How about me?
Yes. Not breaking is not continuous.
Oh, extremely sorry. Would you like me to log out and log back in, sir? Okay, I'll do that. Hello, sir. Can you hear me better now?
Yes, yeah,
Yes,
much
we can
better.
hear you now. Yes, yes.
I apologize for that. I'm extremely sorry. I should have checked the connection beforehand. I'm resharing my screen. Visible, guys?
No, not yet. Yes, now.
Right, sir. I'm putting in presentation mode. I apologize for this, guys. I think the seniors are much more tech savvy than I am, it looks like. Right. I was mentioning in the earlier slide that increasing the length of the neck can give you a good soft tissue tension, but it is also going to increase your length of the limb, like in this picture on the left. But on the picture on the right, by increasing your offset, that is making it more acute offset, you can get a better soft tissue tension without lengthening your limb. So that is definitely an advantage that you can have. The implants which have a option to change your offset really help you in these kind of situations. Next is a soft tissue evaluation. Now that you've done your balancing, you have to check at the end of the case whether you have adequate tautness and adequate stability due to your soft tissues. So first, of course, you have to do your trial reduction. The tension required for reduction of the trial implants gives an idea of soft tissue sleeve tension. You have a very easy reduction. It's just popping in very easily without much of force. It's probably not an adequate tautness. If it's too easy or too difficult to reduce, it may require a change in the offset. So too much tightness is also not a great idea. A shuck test can be used. A lot of people do use it. We were also using it till recently, but it can also be unreliable. If you have a colleague who has a lot of strength, and if he pulls, and a colleague who doesn't have that much of strength, there's going to be a very bit variance in the shuck test as well. So how do you evaluate for flexion contractures? With the hip extended to 10 degrees, flexion of the knee should be able to, with the knee flexed at 10 degrees, should be able to rest when flexed to 90 degrees without undue tension. Okay. So there's also known as a drop kick test. Basically, when you extend the hip, the knee will just kind of kick if it's too tight. That's what happens. If it's too tight, reduce your neck length as long as the limb length discrepancy is not increased. Anterior stability, check with the hip in extension and external rotation. If it's dislocating in less than 90 degrees of external rotation, then you should definitely make some changes. Reduce the cup anteversion and removal of posterior osteophytes, which can lead to posterior impingement and anterior instability. You should have minimum 1 centimeter space between the ischium and the posterior aspect of the GT. Then leg length restoration. Sometimes in the pursuit of adequate tissue tension, we end up lengthening the limb. Too much of LLD is there, we need to assess the cause. You may take a deeper neck osteotomy or place a smaller stem deeper in the canal instead. Again, different neck angles and lengths can help in this situation. Adductor assessment. We always talk about abductors, but adductor assessment is also important. It's assessed by abducting the limb with the limb in extension and midflexion. If it's very tight with a hard endpoint, it's probably because of an impingement of the GT on the lateral aspect of the pelvis or the cup. It can be addressed by increasing the offset of the neck or the head and changing the acetabulum if you're too horizontal. Tightness with a soft endpoint is probably because of tight adductors, and this can be addressed by sterile percutaneous release of the adductor longus after your final implantation. You can go in and do a small release over there at the end. Posterior stability, first check the sleeping position. Take the hip into 90 degrees of flexion with a slight adduction. There should be no posterior dislocation. To check in full flexion above 90 degrees and internal rotation up to 60 degrees should not dislocate either. The different causes of posterior dislocation can be more vertical and retroverted cup, inadequate abductor tension, and combined anteversion, which is inadequate. And anterior osteophytes can also lead to impingement and posterior dislocation. Posterior soft tissue closure is very important with Ranawat suturing technique. So I'll just end my talk with the next 5 slides. The classification and management of an unstable total hip. Obviously, you're balancing so that you avoid an unstable total hip. This is a very good classification system where you have 6 different types. Type 1 is a problem with the acetabulum component. Type 2 is a problem with the femoral component. Type 3 is a problem with your abductor complex, abductor trochanteric complex. Type 4 is where you have impingement issue happening here. Type 5 is all your components are okay, but you have late wear. And type 6 is there's no perceivable reason, but you have a dislocation without having a reason. It's actually the most dreaded one because you don't know how to address it. So let's look at type 1, acetabular component malposition. It's outside the luminec safe zones. You have to revise your acetabular shell if that is the reason. You can sometimes cement a liner into a well-fixed shell. We have done that in the past, where your cup is too well fixed, but it's not in a good anteversion. So you can cement another cup into that in the correct anteversion. Type 2, again, as I mentioned, femoral component malposition. Outside of the femoral anteversion range of 20 degrees plus or minus 10, this you have to obviously revise your femoral stem. Post-operatively, you can check this with CT scans and you can see how much your anteversion of your femur is. Type 3 is a problem with the abductor complex. It can happen when you have a detachment of the gluteus medius or an absence or non-union of the greater trochanter. Here, in these cases, usually you have to go for a conversion to a constraint liner or a dual mobility. Yes, the dual mobility is a very good bailout option in these situations. It's also good if you can try to repair that abductor complex as well. Type 4 is the cause for instability is impingement. As I mentioned earlier, bony versus component versus cement impingement. You have to remove the cause of impingement and go for a larger femoral head. And you can also increase the horizontal offset and the head offset as well to reduce the impingement. Type 5 is delayed polywear. These people may be fine for many years, but after a while, maybe 10 years, 15 years, you start to see eccentric head placement in the x-rays. That means that your polyethylene has slowly worn away, and that leads to instability in the long run. Here, you can try to retain the well-fixed cup and stem and change just the liner and the femoral head, increase the head size if possible. Type 6 is unknown cause. You have to revise everything, acetabulum, the femur, everything has to come out, and you have to retain and change the components completely. And you should end up using a constrained liner in this situation. In every case, be ready for all 6 possibilities is my take-home point. This is a very nice algorithm which I found. I'm not going to go into depth. You can take a screenshot of this. But if you probably have confused, you can probably always go back to this and decide on how you want to take it forward. Or you want to address everything all at once, you can use robotics. I'm not going to go into too much of depth. It's not a robotics talk, but this can definitely address all these issues at a single go. So I'd like to end my talk here.
Yeah, Adarsh, I think very comprehensive. You have covered the causes and the mechanisms and the treatment for the instability. You mentioned about by increasing the offset, you can increase the soft tissue tension without increasing the length.
Yes, sir.
So, why only few companies provide you with the different offset option? What you have suggested, that is the best thing. So, should we try and see that we should use implants where there is such option is available?
Definitely, sir. I think that's a very huge advantage when you have these offset options in your armamentarium. Obviously, if you do a bit of templating beforehand, you know what your native offset on the normal side is. So you can try to plan that way, but it's always good to have multiple options. The Depu Corel does have multiple options, and the Accolade 2 also has a very beautiful option of 132 degrees and 127 degrees. Usually these two are more than enough. You don't need to go for the whole range.
Yeah, I think people should know that which implant they're using and what are the options available for the offset. That is what exactly we should know what you have said.
Yes,
My
sir.
second point is that you said about we should try to maintain the native head of the center of rotation in the femoral head. So, which conditions are there probably where and how much you can accept some higher hip center rotation? So, what are the conditions and what is the limit?
Yes, sir. So, sir is basically, I think he's alluding to dysplastic hips. Dysplastic hips, you're not trying to just remain where you were. Dysplastic, you have to actually change because it's not in the normal position. You have to medialize your cup position, and you can also accept a slightly higher hip center in Crow 2 and Crow 3. Basically, when you have a higher, because the bone stock is better up there. So, up to 1 centimeter of high hip center is usually quite well accepted. 1.5 centimeters sometimes, but that's a little, that starts to cause a little bit of deficiency in the abductor mechanism. So up to 1 centimeter high hip center is definitely accepted in dysplastic hips, sir.
And what is your threshold for the constraint liner?
I have not used constraint liner, sir, very frankly. Because I've read many publications where they say that it fails in the pretty short term. So rather than that, if you can get a bailout with a dual mobility, that should be fine. But mind you, that's not going to be a bailout if you have very bad component positions. So if you are having a situation where you have bad component malposition, revise the components and add a dual mobility for extra stability. Do not depend on a dual mobility or a constraint liner when your components are in a bad position. It's not going to help you. Sir, I think you're on mute.
Okay, my last question. You said that in certain situations, we need to change our versions either of the or in the acetabulum or in the femur. Now, we have flexibility to change the version in a cemented stem very easily because the stems are usually thinner than the canal diameter, and probably you can change little bit of version and fix it in that position in the cemented stems. What is your guideline? Because usually the uncemented stems are press fit. So you don't have that rotational or other flexibility available. So what are the tips? Are there any special stems which we can use where you can get the fixation and also change the version?
Perfect, sir. So this is a very, very pertinent point mentioned by Dipak, sir. You have a good play with cemented stems. You can do a complete 360 rotation if you want to. But uncemented stems, because of the press fit nature itself, they usually take the direction of the canal. So you may have a leeway of maybe 5 to 10 degrees you can change your anteversion. So before I answer sir's question, I would like to mention one method to adjust your combined anteversion. I think by Dr. Pachore sir does femur first all the time. I think that's a very nice way to do it. Do your femur, check your final anteversion that you have attained, and if you find that you're either too retroverted or too anteverted, you can adjust on the cup side. So that's a very good advantage of doing femur first. The question that sir asked was which kind of stems have the option to have a rotational change. Basically, the modular stems like the SROM, you can do a nice fix and then you can change your anteversion on the upper layer. And then you also have the cone Wagners of the Zimmer, which is still a monoblock, but because of its shape, you have the option to change the anteversion on the stem as well. So cone Wagner and SROM are usually the ones which can give you the anteversion play.
Dr. Khincha?
Others, what is the present understanding and thinking about relation of the cup anteversion and inclination based on the spine?
Yes, sir. So that's a whole Pandora's box.
Yeah.
So there is a lot of discussion about this now, like how alignment is the big topic in knees, the spinopelvic relation is the big topic in hip. One thing is, I think everybody is now on the same page that the pelvis is supposed to move, and whatever cup position we do about 40 and 20 is in a normal mobile hip and mobile spine. So one thing that we've learned to do is we take lateral spine x-rays of all our patients now, sitting and standing. You calculate the sacral slope values with sitting and standing, and you find the delta. If it's more than 10 degrees, more than 15 degrees, you have a nice mobile spine. You put your cup in a normal position. It's when you have a delta of less than 10 degrees, when you have a stiff spine, that's when your pelvis is going to not move normally. That's when you have to adjust your cup placements. Now, there's again stuck sitting, stuck standing, and that's a whole different ballgame. But these can be addressed again with robotics. I'm not saying that it's the only way to do it, but I'm just saying that this gives us a lot of information of where you can put your cup. We've found a huge array of placements of cup with these different spinopelvic parameters. There's a very nice paper on this by Vikram, where he's classified into 1A, 1B, 2A, 2B. I would urge everyone to just read that paper, Vikram's classification of spinopelvic relation.
Are we expecting the role of AI coming in quite a lot in this particular module of inclination and anteversion of the cup? Like there's a new one coming out called Intelligent Hip and Intelligent Knee come out in the market with smart AI.
Probably, sir. Elon Musk says we're all going to be out of a job in another 6 years, and I do believe him. So, yeah, I think definitely AI is going to help.
Others, we will probably not be having a time for the bearing choice talk.
Sure, sir. Sure.
But few minutes we have. I have another 2 questions for you. Your thoughts on promoting dual mobility in a primary case for sake of getting movements, marketing, like you will be able to do this and that, and you will be able to sit cross-legged and squat and that. That's one point. And my second point is, there are situations where you also want to do the dual mobility, or probably you are convinced that, okay, patient wants this, that, but your head diameter selection does not allow you to do the ceramic and you have to use a metal as a dual mobility, then I will probably tell the patient coming out that, okay, this is a 50 mm. I was not able to do the ceramic dual mobility, and therefore I went for a ceramic head rather than going for a metal dual mobility. So these 2 points, I want your thoughts.
Right, sir. So I don't think dual mobility is going to be or should be used with the promise that you can do everything like sitting cross-legged and all that. Frankly speaking, a very well done hip, you can still sit cross-legged with a good 36 or 32 head. And I see many patients doing it even if we tell them not to do it. So they can do it. It's not going to actually give you that much more of a ability to do these kind of crazy activities. I don't believe in using it in a primary setting. I know the Europeans do. They use dual mobility in primary setting as well. The theoretical disadvantage of this is that you have an extra bearing surface there. The more bearing surfaces you have, more interfaces you have, the higher chance of wear. So the moment you have a head, then an outer head, and then then a liner on the shell, and then the shell itself, you have 4 interfaces there. So you're going to theoretically have a higher chance of wear in this kind of condition. And of course, there's again a disadvantage of having intraprosthetic dislocations as well, which is one of the documented complications. So, well, the Europeans are having good results, but I don't think it is warranted to use in a primary setting. Now, coming to the next question, you said very nicely, sir, even if you want to use a dual mobility, sometimes your cup size is not adequate to use it. And sometimes the inner head, you cannot accommodate a ceramic ball, you have to use a metallic ball. If your indication for the dual mobility is justified, let's say you have a neurocompromised patient, some cerebral palsy or Parkinsonism, and you really need, that's the actual indication for it, then I would suggest to go ahead with the dual mobility, even if you're using a metal inner head. I don't think that metal versus ceramic in the inner head of a dual mobility makes that much of a difference.
But not in the routine case, like somebody...
No, definitely not. No.
Yeah, so if you have a choice with the COP versus metal dual mobility, of course, your personal choice will be to go for COP.
COP for sure, sir. Unless that there's a proper indication for the dual mobility. Otherwise, no.
Correct. Okay. So I think we are just approaching the time, and Adarsh, on behalf of the Education Committee, the Executive Board, Trustees and President Dr. Khincha, and my colleague Dr. Krishna Kiran, I thank you for sparing your time and giving this very lucid lecture on the hip instability. Certainly, we will keep your talk of the bearing choice for the next academic program, and we'll certainly love to have you for the next program. For all the colleagues, those who have joined and still they are on, please register yourself for the next ISHKS meeting, which is in Pune, 10, 11, 12 April. A fantastic academic program has been choked out with very eminent national and international faculties coming. So please go to the website, see the program. It's of course going to have some finer changes coming up, but overall broad outline has already been made with, as I said, very special sessions, again on instability, on PJI, on bone defects. Lots of videos are there, lots of live in-box surgeries. So very interesting sessions coming up in this Young Surgeons Forum is there. And we have been giving platforms to so many young people. So please come, show your presence, ask questions, and get yourself recognized. And we'll certainly support you to get the podium in the future. So with that, I request Dr. Khincha to conclude this last meeting of this academic year and then say goodbye to everybody.
Thanks, Dipak, and thank you, Adarsh and Dr. Chatterjee, who is not here, for sparing your time today. And I also thank the previous speakers of these scientific meets over the year. And I cannot thank Dr. Dipak and Dr. Krishna Kiran at all. I don't have words to thank them because of the amount of hard work they are putting into this. It looks so easy for us to just come and sit, but the amount of hard work and persuasion Dr. Dipak has done along with this scientific committee. I really thank you from the bottom of my heart. It's been a privilege to be associated for the whole year, and I look forward to all of you in Pune in big numbers, not only in big numbers, but in active participation in the Pune conference so that we take the ISHK to the next level. And also, as you see, we have promoted a lot of young speakers so that we can be phased out and then we can start working for you rather than you working for us. So thanks everybody and have a nice weekend. And we look forward to seeing you in Pune in big numbers along with your colleagues and your peers.
Thank you, Khincha sir.
Thank you.
Thank you, Dipak sir.
Thank you. Thank you. Good night. Good night.
Good night. Good night, sir.